by the time all was said and done, we were actually presenting, having multidisciplinary rounds on a daily basis, because we found it was so useful to have the various disciplines participating. It's not just about Dr. Chandrasekhar running rounds, or Dr. Seshi running rounds. It's about, the issue is that the various different disciplines, such as nutrition, such as pharmacy, such as nursing, all have different inputs that they put into the rounds. And when and we used to ask everyone to come prepared. It's an interesting thing because a lot of places, people come for rounds and they just simply come, but they're not prepared. They haven't reviewed the chart. They haven't looked at the patient. They haven't seen what's going on with the patient. That's a priority issue that needs to be thought about. And we'll talk about this as we go. Let's go ahead and get started, and we will move forward. Next slide, please. Okay, so remember, multidisciplinary rounds are patient-centered. That is, our focus is on each and every patient. Now, you don't have to do this for all your patients. The most sick patients, if you can do this, you'll find that the care will actually improve very nicely. And the emphasis always is on safety and how efficiently we can do this. There can't be, we have to get away from the concept of finger pointing at individuals when things go wrong. We really need to look at processes. And it's based on the principle that we all want to come to work and have success with our patient, right? That's the whole principle. So process is everything. So anytime we can improve process, that is, let's say you've got a patient that you want to try to switch to oral medication from IV medications. The pharmacist will be requesting, hey, can we switch over to oral medication? But the pharmacist may not be 100% aware of all the other processes going on. So the feedback going back to the pharmacist about, okay, the patient's not quite ready yet to do that, but it's a good suggestion. We'll come back to that in a day or two. These are the approaches that the back and forth, okay? And again, each team member, especially people like pharmacists and nutritionists, they really input tons of information, and nursing input tons of information. In fact, I've had times where nurses will come and tell me, Dr. Chandrasekhar, we don't want to be doing this type of therapy on this patient because these are the issues. The patient may be at risk for a fall, we want to mobilize the patient. The nursing says, well, the patient's at too high a risk for a fall. Let's not do that. So we work together in that fashion, and we determine care priorities. Now, it takes a little bit of work on the part of the intensivist to do this. As you're working your team, you gotta let the team kind of build it. Now, you can't let the team also get away from the objectives. You gotta keep them in line, but you also have to allow them to start participating. Because I know in Indian medicine, sometimes it's really difficult for, let's say, nursing or nutritionists to speak up in the face of an intensivist. So again, this is, it takes time to develop this. The other thing that you have to insist upon is establish your daily goals. Priorities in management. What are we, how are we setting up the priorities? So if this is, if the patient is in septic shock related to a pneumonia, put it down. And really speaking, everybody should be on the same page. This patient is in septic shock. So the next question that nursing or somebody may come up with is, hey, doc, if the patient's in septic shock, we should be following the sepsis protocol. Okay, pull out the sepsis protocol and we start doing it. This is how you establish processes. And it's very good in the management of our trauma patients for that reason, okay? So, and again, we found that having social workers also in place facilitated discharge from our ICU because the paperwork and everything would be all ready to go so that there wouldn't be any delay by several days to get the patient out. So, or if we were thinking to transfer the patient, let's say, to a rehab facility or to someplace else or to the ward even, someone checking up to see whether there's availability at the other side on a consistent basis made a huge difference. Next slide. Next slide, please. Okay, so how do they help? You get really good, one of the things that, I emphasize a lot in the ICU where balls get dropped is communication. There was an old American movie called Cool Hand Luke. And, Paul Newman, this is an old Paul Newman, I'm dating myself. Paul Newman was an American actor and he was a prisoner. The other prisoners were beating each other up. And a famous line he said was, gentlemen, what we have here is a failure of communication. And that in medicine is absolutely true. The biggest reason we have failures of systems is a failure to communicate. So good communication, not just between doctor to doctor, doctor to nurse, nurse to doctor, nurse to nutritionist, nurse to pharmacist. So communication all around is improved, okay? And for pharmacists to come to the ICU to make rounds, here's the thing, okay? The problem is they see it as a waste of time. It's not. It really isn't, because it improves their work process, it improves our work process, and overall, it leads to better patient care. So, but we have to value everyone's time in this, and we cannot linger on patients. We have to go through in an organized, stepwise way. We'll talk about this. You get improved compliance with process measures like sepsis protocol. You'll see that you'll be drilling down on every time you do multidisciplinary rounds, you'll be getting improved compliance with ventilator bundle, reduced pneumonia rates. You're going to see this. This is one of the, if you will, side effects of this whole process. But it's a powerful vehicle for getting everybody together and reviewing the current patient status and clarifying what we're going to do today. Then, it's like I always tell people, you got to have a plan. After this lecture, I'm going to go have a cup of coffee. Okay, I've got a plan for me. What about your patient? Do you have a plan for your patient for the day? The patient I hear this statement, status quo. Well, status quo is not something that we really want for our patient, right? Think about it. Now, if you get a cut on your arm, this is a thing that I always explain to people. If you get a cut on your arm and you get it stitched up, every day in every way, that stitch gets better and better and better and better until you get the stitches out, and then the wound heals slowly. You'll end up with a scar. Very true. In that sense, in the ICU, you should be seeing improvement in your patient on a daily basis. If you're not, that means we're missing something. So again, think about a comprehensive plan of care, not just about, and the thing is, and I'm not even talking about the chronic issues. I'm talking about the acute issues. And we really have to discriminate with chronic issues, because oftentimes, and I see this a lot in our notes and stuff, that, the emphasis is on the chronic issue, the lung cancer that the patient has, or the breast cancer with the lung mets. Well, that doesn't cause acute problems. The acute problems are, let's say you got a post-obstructive pneumonia. That's an acute problem. So you have to figure out how you want to address the acute stuff, and you also have to think about the chronic stuff. Next slide. Okay, so now what else does it do? It also provides an avenue for you to have discussion with patient and family. So it's a very good way, because number one, you're identifying safety risks. Let's say the fall risk for a patient, or the decubitus risk of a patient. All these things that, we take for granted. We think, it's extra work to do. It's not, because you're actually covering it as part of your approach. If your approach is consistent, here's the other thing. You won't miss, things by omission. And errors by omission are the number one reason. Institute for Health, in medicine in the United States, that's what they showed. We have 1 million lives that are lost because, we're omitting issues, not intentionally, but we're so busy that we forget to check off that box, if you will. And the consistency of approach really helps with that. It also helps with educating and teaching our people. Our nurses need to be updated. The best way to learn experiential knowledge is to do something over and over and over again, right? I mean, in Hindi, we call it abhyas, right? A practice, right? As we do practice, it gets better and better and better and better. So again, the consistency is there. The other thing that it allows for is, as we're documenting, we'll be able to go back and look and drill down on various areas for process improvement as well. So this really kind of plays into the whole picture. Next slide. Okay, so the potential impact is you get improved communication, high levels of safety and reliability of care. You get reduced errors, reduced ventilator days, reduced central line days, reduced length. You notice all these things are getting better and better. Why? Because we're doing things in a consistent manner. The biggest thing that we learned about critical care is consistency is the most important thing that we can emphasize in any ICU. And that's where, process issues really come into play. And that's how you have to think. And like I said, I mean, if you got 1,000 docs managing 1,000 patients, wonderful, no problem. But if you have what we have, which is limited number of doctors and limited number of nurses taking care of a whole bunch of patients, then doing things in an organized and systematic way really makes all the difference in the world, and outcomes get improved. Next slide. And what you have to do is start slow, but again, the structure is essential. The leadership has to be there. That is, each of the specialties, okay? Initially, when we started our multidisciplinary rounds, we used to have the chief of nursing who was in the ICU, the ICU chief nurse would participate in our rounds, and she would get her nurses involved so that they would carve out a time that they could come and stand there, and they would organize their work around the rounds. So that's how we did it. And as we were doing it, the patients and the families understood what time we would be doing it, because we were doing it on a consistent basis. So because of that, the family would be there. And what we would do is, as we were discussing, we would, chime in with the family and explain what we're doing and how we're doing it and what the goals are. And we used to have a dry erase board in each room, still do, I mean, in those units, and we write out what the goals for today are. So the family sees, hey, they got goals. They know exactly what they're doing. And again, they're paying good money to take care of their loved one. I get it. And we should all get it. But if they see that we're attentive and we're doing a systematic approach, they're going to trust us a lot more. And our consulting doctors at bedside will be more trustful of us when they see these goals for the day and so forth, and engagement of families and so forth. So, and again, measurement matters. Every time we're looking at a patient, we should be documenting and looking. And it doesn't mean you have to order tests. It means that we have to be more precise in examining the patient. We have to be more precise in how we're talking about the patient. So these are things that, I'm not talking about ordering more labs. I'm talking about even our physical examination and our blood pressure measurements and so forth. How often do we really look at that trending? How often are we really looking closely at that heart rate? How often are we looking really closely at that urine output? That is something that is extremely important, and you don't need additional tests for that. Next slide. But when you do order tests, we should look over them, right? And again, you define and you refine your goals and aims as you go. And what do you want to accomplish? What are the disciplines that are involved? And you can see as you get more disciplines involved, you may not be able to see all the patients with all the disciplines. Very true. So start slow. Okay, start with as many of these people as you can on 1 or 2 or 3 really sick patients. This way, you start the process, you start moving forward, and people start understanding, hey, this is a beneficial thing. Let's start doing it. And again, goals need to be reviewed. Goals need to be presented. And the more people see, let's say the pharmacist, they see, hey, these guys have goals that they want to get the patient off the ventilator. They want to, once the patient stabilizes, they want them on oral medications. Oftentimes, it's the intensivist is so tied up with so many other things that he's thinking about or she's thinking about that we don't have time to say, hey, can we shift that IV medication to oral? Yeah, that sounds like a reasonable thing to do, but you notice how, until and unless it's brought up, people don't think about it. And again, a summary of what's going on with the patient, family-friendly language. We don't speak in jargon, but we try to explain each of the things. Yes, it takes a little longer. Don't deviate from the path. I mean, if they're asking questions, if the family starts asking questions that are off kilter, let's say they want to talk about, the availability of ECMO or this or that, what you need to do, the people guiding the rounds need to do is say, we can discuss that at a later time. I'll come back after rounds and we'll have that discussion. But during rounds, you want to keep it focused. Next slide. Okay, so again, you're assigning responsibility, you're selecting each discipline, and the pharmacist who's rounding with you needs to know what medications that the patient is on. So they have to come and, if you will, pre-round so that they can speak to what medications the patient is on. And again, as we're doing these rounds, I end up restating the focus, keeping the focus on the patient, keeping the focus on what are our goals for today? What are we doing today? Not, oh, we did this 2 days ago, it didn't. Okay, what are we doing today? So we need to have a plan. So again, constantly reiterating the goals is very important. Next slide. And leadership is key. Okay. Each specialty person needs to be focused and ready to go. And if we're starting rounds at 10 o'clock or 9 o'clock, we got to start at 9. We can't start at 9:10, 9:30, 9:40. No, 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 no. Doesn't work that way. Okay. We start at 9 o'clock, 9 o'clock we start. So that's how it has to be. And people who are in leadership position need to be held accountable to that. Now, if you don't have that specialist, okay, that for that starting time, you're going to start. And soon enough, I will tell you this, those specialties will start showing up exactly on time because they understand this guy is going to start or this lady is going to start on time. I got to be there. And that's how you work it. Next slide. It's leadership by example, by the way. Okay. So again, very important. We set the goals for the day. That is your target. Okay. And they need to be documented, not only on a dry erase board in the bed, in the room next to the patient, but in the chart, everywhere, so that no matter who you ask, whether you ask the nurse, whether you ask the respiratory therapist, whether you ask the pharmacist, they all know what the goal for the day is. Everybody is on the same page. And let's give you examples. If you're going to set goals for the day, don't make it nebulous. Oh, we need to monitor neuro monitoring as needed. No. Okay. My target is this. I want to discontinue oxygen by this time period. I want to wean off pressors by this time period. You don't just put a time on it, put the clock on it, circle back, make sure that we are able to put a responsibility as far as timing on it. Put the pressure on. Yes, we're part of this. Okay. And yes, these are expectations. Are we going to meet the expectations 100% of the time? Maybe not. It's okay. But at least we have a goal up. Now, we couldn't meet the goal for these reasons. Okay, that's got to be documented. But everybody in the team knows that we have a goal and we got to get there. So this puts the feet to the fire, if you will. Okay, so this is how it has to be. Next slide. Okay, you engage the family as well, because I will tell you this. Okay, they bring a very unique perspective about they'll say, oh, he may not respond to that, or she may not eat, as much as you want her to. So again, the family's input becomes very important. Okay. And as you're discussing with the family, explain to them, okay, this is our goals for the day. Then here's the time. Here's the timeline that we're doing. Don't forget timelines. Okay. One of the things that I see a lot in a lot of ICUs, people don't put down a timeline. You got to put down a timeline. Okay. And you got to follow the timeline, and you got to see that, people who are reviewing the process as well are going to be looking at that timeline. So you better be prepared. Okay. The discussion has to be focused. It cannot drift out. Oh, all these people are wandering in and out of the room, nobody is paying it. See, if somebody is talking that way, if the family is talking that way, what you have to say is that will be discussed after rounds. We'll go over that. But here's what we're doing now. Bring them back. Focus on what needs to be done. Don't get distracted. That's important. Next slide. Now, if the family gets unruly, obviously you're going to send them out. Okay. Testing the result in improvement. And I'll give you an example. And actually, I'm going to show you an example as we go, because, it's not just about saying we're going to get improvement. we got to test for it. We got to measure our processes. So, how many days are we doing the multidisciplinary rounds? How are we tracking what we're doing? What outcome measures are we looking at? So we really need to look closely. And this means people have to be dedicated to this. You can't just say, well, that we're going to add this on to your job description. No. Okay. What we need to do from CP perspective or any ICU perspective is to be able to get to the bedside team and say, listen, someone has to be assigned and given time to be able to review the outcome measures, to track the outcome measures. We'll show them how, but they need time to be able to do that. You can't just keep piling things onto people and say, oh, they're going to do it. No, they won't. Okay. Unless they're, crazed lunatic like, I was for about 20 years. But again, crazed lunatics are few and far between. You're going to need those people that are dedicated, but have a limited time. Okay. You need to give them more time in that process. So important to think about. Next slide. And again, 3 fundamental questions. Very simple. What are we trying to do as far as this patient is concerned? How will we know that this change is an improvement? And what change can we make that will result in improvement? And we'll talk about this. Next slide. Okay. Example of process improvement in nutrition. Okay. This is at one of our hospitals that we service. For some of you know which hospital, but I'm not going to, delineate that. But, just dietary issues, dietary area before education. This is what it looked like, okay? Where the vegetables were stored, where the supplies were stored, you could see the difference, okay? Next slide. So our personnel went and educated the people involved with the processes so that everybody on the team understood what our goal was. Next slide. Then you see, and the process improved. And then what we had was we tracked it out several months. And every month we asked them, okay, post pictures so that we can see exactly what's going on. And because we tracked it, they've consistently improved now. So their process is improved. The key here is, are you able to sustain that improvement is part of the question you have to ask. Okay. And each and every process is important. It's not just about, only the processes in the ICU. Remember, a lot of things impact what happens in the ICU. If you have a contaminated dietary process, well, your patient's going to get sick as can be. Okay. And if the patient gets a dysentery in the ICU with all the other illness and stuff that they have, you can see how much that would compound your headache. So think about that. Next slide. So how do we get started? Okay. Leverage the existing rounds, but okay, seek additional willing participants, bring them together. Okay. Start small. You don't have to have everybody there. Start, maybe add pharmacy, add nutrition, get them together. Okay. Choose one process at a time to focus on. So you can select which patients you want to do multidisciplinary rounds on. Okay. So if you got, let's say, a patient with sepsis, okay, I want to focus on sepsis protocol. Okay. So I'm going to work on these 3 patients that have sepsis. Okay. So develop and document a daily goal for those patients. Work through it. Okay. And use simple tools to guide rounds, short checklist. Don't make it very complicated, but go through it thoroughly. Okay. Then, okay, you start adding support services gradually into the process, into the mix, and you track your interventions. Okay. Like we did with the nutrition. That's exactly what we need to do. Okay. We noticed the nutrition aspect right off the bat when we entered the hospital, that were this hospital was doing major cancer surgeries. And because they were doing major cancer surgeries, we were looking at them and going, well, why are we getting infection? Well, the patient's nutrition may have been impacting the problem. So we needed to correct the nutritional issue. And when we saw the nutritional issue, we actually had our dietary professor come there and comment on exactly what needs to be done, what steps need to be taken. And with that, we were able to see improvement. Next slide. So you got to have scripted questions. Don't walk in, say, okay, we're ready to start rounds. No. Okay. You gotta prepare. Okay. The intensivist needs to prepare. The participating people need to prepare. You gotta know what you're talking about as far as the patient is concerned. Okay. So each of the things that we're going to discuss, you need to be thoughtful about where we stand with this patient and where we're going. Okay. What needs to happen for the patient to be extubated? Where are we on the checklist for, weaning and extubation? Where are we on the checklist for sedation vacation? So these are things that we need to be able to put together. Okay. And what needs to happen for the patient to be discharged from your ICU? So you gotta have answers to these questions. But you don't, as an intensivist, you don't need to provide all the answers. What you need is input. Okay. And then that answer will arise from that mix. Next slide. Okay. And again, start slowly. Start with 2 or 3 patients. Okay. You don't have to round on everybody in this way. But once you have your process going, you'll find that the efficiency will improve. And as efficiency improves, you'll be able to do more and more patients. Now, I'm not talking about the in and out patients. I'm not talking about the fast track patients. I'm talking about the patients that are really sick, the impact cases that you guys publish on. These are the kind of patients, because those patients have identified themselves. I'm sick. They've identified themselves. Those patients you want to be doing these kind of rounds on. So that, and it's not just for trauma. It's for all ICU. Multidisciplinary rounds, originated in trauma, but we use them for all ICU patients. So again, think about how you want to bring the different groups in. And again, social workers, physical therapy was a big boon for us. Okay, because patients who were even bedbound, doing range of motion exercises on a daily basis, we found that those patients got off ventilators sooner. We were able to get them moving. So again, the issue here is that as you expand, you'll get more and more people involved, and you'll get more and more input, by the way. So this is how you have, and people have ideas. Okay. It becomes an idea factory. Next slide. Okay. So that's how I want you guys to think about multidisciplinary rounds and how processes. It's all about process. It's not about, what can I do? It's not the quality of physicians or nurses that are there. It is how we work as a team. Please understand this. Okay. When you look at cricket, for example, I'm gonna go to a team sport. You don't have to have all-star players, but the combination of players that are there, okay, produce a winning team. That's your goal with multidisciplinary rounds. That's the key. So, any questions? Yeah, Vijay.
Yes, sir. Thanks for the presentation. It was really a nice presentation, sir. I'm Dr. Bijay from Kathmandu, Nepal, and
Mhm.
I work in a surgical ICU where it's more like an semi-open ICU, where I'm also a part of team. And then many times, okay, while conducting round, it so happens that there are different concerns from the surgery team, from the medicine team, and from the core yeah, intensivist.
Well, you're going to have different people coming in,
Our
right?
heads out.
Yeah. Well,
Yes, sir. Yes, sir. Then the problem that I feel is one. I feel there is a big problem. It could be my own problem also, but in on a general basis, also the problem is with proper communication and proper. I feel difficult to make them understand my concerns because, like for example, I'll give you an example. There was a patient who had undergone hemicolectomy just yesterday, and he was on epidural with bupivacaine and this opioids. So the surgeon wanted that epidural steroid opioids to be stopped because there could be chances of paralytic ileus. And I was more in favor of epidural opioids because I was saying the systemic absorption is very less. So maybe the degree of pain that it can control and the advantage is better. So I many times you feel there is conflicting views and maybe okay. What do you think? What can be the solution for that? Like.
uh, well, the issue here is looking at, number one, as the ICU doc, you have to look into the evidence basis. And the evidence basis clearly says epidural is a good way because you can reduce the amount of opiates that you provide to these patients. And the degree of ileus actually is less
Yes.
with the epidural in play. The epidural has its own disadvantages. You have to keep the Foley catheter in. You've got other issues that you have to deal with. But for the
Mhm.
first couple of days, utilizing an epidural is a reasonable issue, but it forces everyone on the team to look at each aspect of the care. My suggestion to you is, as you're doing multidisciplinary rounds, set up your
Mhm.
multidisciplinary rounds. Start doing it on one or two patients. Don't do it on all, but do it on one or
Mhm.
two patients start once a week or once every 2 days. And what you'll do is, as you're doing this, one, you'll be able to you obviously the communication is going to go back to the surgeons and the internists and so forth. And as
Mhm.
it does, as the communication goes back and forth, what they'll say is, hey, on so and so patient we had much better communication because we had the multidisciplinary rounds. Perhaps we could do that with the other patients. So as you slowly
Mhm.
start developing this, communication is everything, absolutely. But it also means that you have to do your homework much more than
Mhm.
the other guys, because what you can do at that point is say, because this is your bully pulpit, if you will. You can say, hey, for the first 2 3 days epidural is great, but after that, we're running the risk of catheter associated
Mhm.
urinary tract infection, this kind of thing. So again, you can introduce ideas of, hey, maybe
Mhm.
by day 2, day 3, the pain levels are down. Can we get the epidural out? Once the epidural is out, perhaps we can start developing a pathway, and
Yeah.
develop pathways for your patients and say, it does, and one of the things that we did as we developed pathways for like hip fracture patients and, hip replacement patients, what we did was we actually created pathways, and then we took the pathways to the various groups and we asked them,
Mhm.
is this okay with you? Are you okay with this? Now, it's a little more work on our part to do that, but what it does is it eliminates variance. Once they agree to
Mhm.
the pathway, then what you say is we're following the pathway. We all agreed to the pathway, sir or ma'am. Isn't that right? So this way, we walk the team through the
Mhm.
process. That's how you have to do it. I'm not saying it's going to be easy, but what you need to do is start slow, slowly build, and bring in, the groups. But that means, again, preparation is everything. You have to do your homework, and it's not easy, from that perspective, because I'm constantly reviewing what the current literature is from neurosurgery, what the current literature is from anesthesia. So I'm looking at each of these things. But the good news for you is you have help. You have cloud physician behind you. So what you can ask is, the academy at Cloud Physician, you can ask, hey, are there protocols, are there pathways, are there things that we can utilize for these kind of things? And we can help provide that for you and move your system forward. So that's how it can go.
Thank you,
Very
sir.
good, very good. Any other questions? Sanat.
Yeah, hi.
Hi.
Uh, might be related to what Dr. Vijay told, but how do we avoid ego clashes in these multidisciplinary rounds? Any tips on that?
Well, I mean, yeah, listen, you slowly work people into where you need to bring them. Okay. It doesn't happen overnight. You have to keep coming. And as you run mortality and morbidity rounds. When you're doing mortality and morbidity, does change happen immediately? No. But we have to just keep bring the horse to the water, and slowly they'll drink. I promise you. But multidisciplinary rounds is one of the ways you can. It's a bully pulpit to convince people. This way you bring them. You work on one patient or two patients. That's how you're going to do it. It takes time. And by the way, if you want to run it from CP, you can, because you can get everybody at bedside. You got camera. You can stay, sit there at your computer and be able to, have the discussion and ask, okay, what does the bedside, consultant feel about this? What does, but keep it focused. It's extremely important to keep focused on the issues at hand. Don't let them get out to the periphery. This happens a lot. They try to, we're overly medicating it. These generalities have to cease. What you have to do is you got to bring them back into focus and say, for this patient, what do we want to do? For this patient, how do we want to address? So that's how you got to keep coming at them, and it will come. I promise you, but it takes time. It's not an overnight thing. Dilip.
Hey, just wanted to address Bijay's point, Bijay Casey from Kathmandu. And what's another thing? See, I think what you said about evidence base is true. Knowledge certainly helps, and it will help make the case. But I think what we need to work on, and not just as intensivists, any specialty that you are, or any specialty that you practice, and you want to help the patient, I think body language and tone is very, very important. And in a multidisciplinary rounds framework and in a cross consultation framework, that body language and tone actually can be the difference between your opinion being taken seriously and your opinion not being taken at all. And what I'm trying to hint at is not to be aggressive, but controlled, assertive tones are important when you're trying to convey something. And that will put you in a better framework to actually be successful. So if you look at successful infectious disease practitioners or pulmonologists or intensivists, whatever the specialty may be, in fact, that controlled assertiveness is what is going to make the consult successful. So like you said, you'll have to set the goal first. What do we want for the patient? Is our aim pain control? Do you want the best pain control possible? Arrive at that, mutually agree on that. And then with an assertive sort of a tone backed by evidence, make your point. Because I think if you're going to take a submissive tone that this is what I think, then you do whatever you want, that is not going to work.
No, you
My
have to,
suggestion would be,
and I
you have
agree.
to actually build that case, right? You have to say that if your goal is this is what we should do. Not if your goal with this, some people suggest this, I suggest this is what I think, then it's up to you. That is not an controlled assertion. I'm not, it's not to be confused with aggression. You don't have to be rude. You don't have to be defensive or paternalistic. There is, you've got to actually, that's a trained skill, right? And there are books written about this. So this, I think, is a pretty important point.
Yeah, and I always emphasize, you can speak obligingly without obliging the other person. There is a tone and way you explain things to people. And yes, it is not, you're laying down the law, but in a nice way. It's what I do with, what I used to, at least. It is harder with my kids, by the way. With my kids, you have to say no, but make them understand that, I'm not saying yes because of these reasons, and I have to give you a no, So again, that's hard. It's not, takes a little longer. It takes a little bit more patience and persistence, but I think, we should be doing that. Any other concerns, comments? Sashi? Any concerns, comments, any input here?
No comments, Akella, but I just wanted to actually tell it was a fantastic discussion and more practical oriented of what we need to do. I mean, sometimes many of the things what whether it's Dr. Vijay or Dr. Sanath explaining, in the Indian scenario, there are always going to be issues of this, but persistence, like what you say, taking it slow, maybe the way to go. And I really liked some of the, especially some of the points where putting down the list of things to be done in front of the patient on a whiteboard so that they get ticked off at the end of the day gives the family into confidence. These are the simple things we can take step by step approach to improve our own processes. So that's fantastic. And I would just want to comment on this. Thank you.
Thank you. I mean, that's, the whiteboard thing, the dry erase board in each room is actually a great thing, because that it keeps my nurses focused on what they need to look at, what they need to do. But the more important thing, we found was attaching time to everything. If they see the time and they're looking at the clock and they're seeing the time, they're looking at a timeline. Boy, they really kick in. And that is what's most important. At that point, boy, they really feel, oh, the doctor put 4 o'clock. I have to get this done by 4 o'clock. So I'm going to, and what's interesting is, priorities in management. How do we prioritize what we're doing? I understand that nutrition is a priority in patient that's in ARDS, but nutrition is not the top priority, right? Ventilator management is top priority. So again, each patient, we need to be able to say, okay, I'm going to focus on the top 3 things today. The rest, I will be there, we'll address it, but this is my priority. And that has to be reflected not only in the dry erase board, but in our notes, so that everybody's looking. If you ask anybody in that ICU, if you ask them, what's the priority for bed 5? They should be able to say, okay, we're going to do this, we're going to do this, we're going to do this, we're going to do this. Done. Okay. You don't have to give a laundry list. Give 3 items. Tell me 3 items that we want to do, or 2 items. I don't care. Make it simple, but give them something straightforward so that they can all repeat it, and make them repeat it. Because they need to know, and nurses have to understand that. Yeah, Vijay.
Yes, sir. Like as you're talking about nurses, the one thing which comes to my mind is nurses, especially in this part of third world countries, they are underpaid, and more than that, they're under empowered, and their role in this hospital, especially in the ICU, is not actually credited to that level as it has to be. So right from how do we start that, how do you do that, like bring them into the picture, making them come into the rounds, okay, making them
First,
feel
uh,
yes.
first of all, empowerment is more powerful than you can imagine. If you
Mm-hmm,
notice nurses that are wanting to get involved, okay,
mm-hmm,
number one, encourage them. And number two, okay,
mm-hmm.
promote what they do so that, and publicly, one of the big things
Yeah,
I see is nurses in India as well. I'm sure it's the same thing in Nepal. But the
yeah,
thing is that nurses are afraid to speak up because the doctor will say, ah, that nothing. That's not
yeah,
the way
exactly.
to deal. Because, and that due respect, whether they're underpaid or not, if they're given due respect, trust me,
Mm-hmm,
they'll stay and they'll work. And because the reason they went into nursing is the
mm-hmm,
same reason we went into medicine, is they want to
exactly.
help the patient.
Mm-hmm,
Common goal. So keep emphasizing the common goal, and keep emphasizing that when they
mm-hmm,
do a good job. Here's the other thing that I tell people all the time. There was a American football team called the Dallas Cowboys. And they were a horrible team. They had a completely losing record, and a coach took over. And every day the coach would comment on, you know, the good things the team did. That every week the guy would comment on, oh, we did a great job at this, we did a great job at this. The team still lost, but over time, what they started doing was they started understanding they were doing things right. So it was just a matter of time before they started
mm-hmm,
winning. Same is true with your team, your nursing, your people that come and clean the ICU, people that work, that clean up the patient, the nutritionists that deliver the meals. Everybody on the team, when they do it, we have a habit of, unfortunately in medicine, if you do something wrong, you yell at that person. But unfortunately, we don't compliment people when they do it right. Compliment them. It takes
yeah,
only a couple of minutes, you know, and even if the outcome is poor, the patient died, okay, but that nurse worked their behinds off to try to keep that patient alive. A little word that says, hey, you guys really tried. Uh,
mm-hmm,
I have nothing but praise for what you guys did. See, the moment you say that, let me tell you,
mm-hmm,
you just scored 100 points. Okay. And the whole thing here is that small compliment carries so much weight, so it is important. And yes, we're going to mention where we went wrong. Yes. Okay. And when I'm looking at things that went wrong, I always say we. Whenever something was done right, I try to say as much as possible, you guys. Okay. Notice how that really helps. And it really does. It's so important. The leadership
mm-hmm,
has to be such that, you know, I want to say, you're not self-deprecating, but what you're doing is you understand your value. You know what your value is. It is not about you, it's about the team. And you got to get the team more confident. And I'll tell you this, over a period of time, you do that enough times, they will speak up and say, doctor, this is not going to work with this patient. And then you ask them, why?
mm-hmm.
And then they say, well, these are the things that are going on with this patient, and this may not work. That's the position you want to get your team to. And here's the other thing. Don't emphasize on outcomes. Patients live, patients die. That's not in your hands. Excellence in your work is in your hands. So I always emphasize excellence in how we do things, not about outcomes. Yes, good outcomes come. Yes, sometimes you will get. Sometimes the patient won't make it. Okay, we recently had a patient in one of our hospitals that had a pulmonary embolism. We caught it. We resuscitated the patient. We thrombolized the patient. The patient did well. And the patient came off the respirator. The patient was, getting ready to be transferred out of the. This is, that's a great outcome. But even if it's not a great outcome, okay, is there room for improvement? Is there a way that we can make it better? Okay. Can we recognize it faster? And you need input from everybody on that front. You need to speak with them. You need to pull them aside and say, hey, what do you think? Are we doing this right? And yes, that person's a nurse. It's okay. They're going to tell you what they think. Now, they may not understand the evidence-based medicine. Very true. But if you discuss with them and you spend the few minutes, trust me, it doesn't take more than a couple of minutes. And the other thing when you're discussing, one of the things that docs don't do is my suggestion always to docs when you're discussing with patients or with nurses or staff, sit down. If you sit down, the perception of you taking more time with them is given. Okay? If you stand up and if they're sitting down, doesn't work. You got to sit down and be at their level. Sit down, or have both of you sit down. The perception is, even if you spend only 2 minutes, the perception is you spent a lot longer time with them. Okay. And that is important for all doctors to recognize. Okay. You need to do that. Yeah. Any other questions? I think we've gotten our message across.
Thank you.
Okay.
Thank
Have
you,
a good
Akella.
day, guys.